A very good afternoon, ladies and gentlemen. Despite the squall, we've welcomed you today, for those of you who've made the effort, and we welcome Dr. Jayaranjan Ram and Dr. Soumitra Shankar Datta for coming and giving us their time and making the trek through the squall to talk to us about Unveiling Cancer Journeys, a photographic exploration. Dr. Jayaranjan Ram, will you hold up the book, please? Both of you. This is the wonderful documentation recording that has come out of their journey together, where they collaborated on what really happens when a cancer patient comes into a hospital. What happens to people who are already supposed to be the caregivers, the clinicians, the doctors, who are analyzing the reports, and do they understand what the family is feeling at that time? So there's a lot of quotients here, emotional, clinical, physical, and I think it is very auspicious and propitious that in a climate where cancer seems to be a pretty common word in households. Unbelievably, just out of the blue, I was meeting someone for lunch today, and I never knew that she was a cancer survivor with kidney cancer. And because I knew so little, we were talking exactly about what it was like to be without one kidney, and how her family, did they not want to donate another kidney? And she told me, one kidney you can live with if you live properly and you live with the correct indicators. So, without further ado, let me say that we are so grateful that Dr. Jayaranjan Ram, renowned psychiatrist based in Kolkata, founder of the Mental Health Foundation here, and Dr. Soumitra Shankar Datta, a research active clinician, consultant psychiatrist at Datta Medical Center, Kolkata, who's been there from get-go at the Datta Medical Center. We'll be having a conversation exactly on this symbiotic, hopefully symbiotic relationship between the journey and the people who are either sufferers or the healers. So without further ado, the floor is all yours.
Thank you, Dr. Mehta, for the introduction, and thank you for all of you being here. And I would also like to thank, Soumitra for agreeing to do this. So it was actually, Soumitra and me, we go back a long way. And in 2019, he one day called up and said that I have organizing a photographic exhibition of the cancer hospital, and would you just come and have a look? So it was a very curious kind of thing, because you don't kind of hear hospitals organizing exhibitions of photographs which are taken in the hospital. And when I went there, I realized that Soumitra has talked to a person called Mr. Shomendu Shaha and took about 3,000 or 4,000 photographs of the hospital over a period of few months, and then he had some funding from the Wellcome Trust and then curated it and put it in the hospital corridors and various rooms. And personally for me, like all of us, we know people who have gone through cancer. We have lost very, very close people to cancer, and I don't think there's a single household who doesn't have an experience of what this whole thing means. And personally for me, it was a very evocative experience, and I hadn't experienced anything similar to that. So, and then when Soumitra brought out the book, and it's in the second edition, I thought it really merits a wider exposure. So what what we would do today is we will have few questions and answers, and then Soumitra will show some of the photographs which were taken, and then we will have a discussion. And so I would just like to kind of begin with the context of what made you do it, because this is something, a very alien idea, that cancer journeys, there are stories of other mental illnesses where photographs have been taken, dementia, but for a cancer hospital to organize this, I think, is a very strange concept. So what made you do this was my first query, really.
Thank you, Dr. Ram. So, both of us have collaborated for a time now, and I would be not doing justice if I say that Dr. Ram really helped us crystallize the idea after the exhibition going on to the book. And thank you to Bengal Club for inviting me. Now, what really I thought about was, there are only certain things which can be expressed in words. And cancer evokes an emotion, because as a psychiatrist, I have been seeing patients, family members and staff in a cancer hospital for almost a decade then. And I realized that there are lots of uncertain and unexpressed things which people have not said. And we wanted to build a bridge, because if you see in the last 10 years in Kolkata, medicine is going through a crisis where people don't, people are skeptic of doctors, people are suspicious of various things, and doctors, on the other hand, also, I think, have their own share of the way we have carried ourselves. And if we can have an art project, because, as you say that, art connects people. Words may be poisonous, but art connects people. So, just like the patient who has lots of stories which the doctor may not have had the time to listen to, many stories of the patients, doctors don't know, and many stories of the staff of the hospital, they don't express it to patients and their family members. So there is an opacity once you go through the walls of a hospital, and sometimes hospitals can be really scary. And particularly if you're having a diagnosis of cancer, you are already emotionally aroused and you don't know. And I think the idea was to bridge that gap. That's where we came the project. I would also, apologize for this, that, I thought it as a project in general. So it's not specific to Tata Medical Center. So I think this is a story which is there for any cancer hospital where these steps we go through. And the idea is to build a bridge.
Yeah. So I think let's kind of go through some of the photos, and then we will have a I think if you show the.
While we get the photos ready, it might be a good idea if you talk to us a little bit about psycho-oncology. What is psycho-oncology?
Yes. Thank you. That's a very nice question. So, I personally prefer the term psychiatrist or a psychologist, because it's less mysterious. Psycho-oncology deals with, if you see, there are certain behaviors which happens before somebody develops cancer, which could be tobacco smoking, or not attending for screening, or attending for screening. So the fact that somebody enters the room of a doctor is a behavior. So behaviors which happen before somebody has developed cancer or after you are diagnosed with cancer, not everybody, some people actually go through it very well. So people can have depression, and once you are absolutely well, some patients, particularly in the initial few years, they might have thoughts, what happens if I get back the disease? So psycho-oncology deals with all the behavioral and emotional aspects of the patient and the family members and the staff which they go through. A friend of mine, an anesthetist, asked me that, I have been referred to Dr. Soumitra Datta, and if I go and meditate that I don't have cancer, will I get rid of it? And he had replied that, no, he's good, but he's not as good, so you still need the surgery. So I think, that's the problem with jargons. I think, it's, we're all mental health workers, I think, but we are focused on patients with cancer. That's the gist of it. So, So as I was mentioning, can I walk and? Yes, yes. So as I was mentioning, that we need, we see doctors and nurses in a hospital, but most institutions run because you need the housekeeping staff have, particularly in cancer, because you have a disease where the body cells are dividing rapidly, and the medicines or the treatment which is done against it might reduce your WBC counts and you become prone to infections. So housekeeping staff is very important in a cancer hospital. And, the managers who manage the quality, the funders who do it. So everybody is in this picture. And I thought, we all read about, life stories of cancer survivors, and they're depicted very well in many movies. And I thought today's talk, I will take you through a journey from the point of view, not from the patient, but from the point of view a care provider. As we work in a cancer hospital, it is a vulnerable position because you are dealing with a disease which can have unpredictable nature, and maybe we are not as like that man who is balancing the rope, but we are trying to balance many things. And as you go in, you might see staff, but staff also feel quite lonely, in their silos working the way like the two crows at the top. I don't know if you can see that. Now, let's think of Shubir. Shubir is a housekeeping staff. He has come to work in the morning. He had his wife was sleeping, and he woke up, and there was the alarm ringing, and he had to cycle his way to the hospital. He lives nearby. And while he was going in, he was thinking, this might be just another day in his life, but every day is different because you're dealing with different people. And the first people you meet in a hospital are often the admission desk, or often the outpatient billing counters, receptionists, and people have lots of questions which they expect to get a precise answer, and the answers may not be always known to them. See, suddenly a doctor might take leave, and the guy who is giving the admission, the appointments, may know it after a couple of days. So these are real life things which the first line of defense often has to handle. Costs of various things. And then Shubir takes the patient to the doctor's clinic. And the doctors, often you might be number 2, but you are not being called. And what happens is that there might have been other patients who have presented to the emergency, and the doctors are talking within themselves. So this is a junior doctor talking to Dr. Rosina, discussing the management plan. He's now a very good surgeon in Lucknow. They are busy often and trying to do their best in the short possible time while you wait in number 2 outside. Now, the wait can be quite, chilling for sometimes. This lady, if Kaberi, let's talk about her as Kaberi, let's give a name. Kaberi's husband waits outside while she undergoes a mammogram. And, every year she comes back, she thinks that what if I have a relapse or a recurrence, yearly mammograms, and husband is very supportive and waits for her to finish it. All these departments which go through nuclear medicine, or X-rays, they deal with radioactive material. That requires itself legislations and safety and quality control. And see, cancer is a tumor, and when you take an image, it's a picture, and it's a 2-dimensional representation of a 3-dimensional object. So although it's after all a shadow, and like all shadows, it may not be always clear. So this is one of our medical oncologists discussing with 2 of the radiologists about how to interpret a particular shadow. So hence, sometimes the reports may not be always straightforward. it takes time to interpret. Kaveri was suddenly told that she needs to be admitted while she saw her doctor. This was not expected, and you can see Shubir taking Kaveri up through the lift with her daughter standing with her, and slowly the evening happens and the sun sets. Hospitals change at night often. Lots of people, I have felt, lots of people known to me tell me. Kabari requires a surgery, and as you can see that there is light focused on the spot where the surgery happens. But at the same time, there is lots of activities, nurses have to bring in certain equipments, housekeeping staff has to bring in things, take out things, the specimen has to reach the histopathology lab, and all of this is in the dark, but these activities happen, and they are happening. So surgery, nowadays you might be talking of robots, and although it's advertised as robotic surgery, robot doesn't operate. It's human beings who operate. The advantage of a robotic surgery is, human fingers have a limitation, so the robot can work on 360 degrees. That's what my surgeon friends say, and there are other advantages. But at the end of the day, it's about a human being behind the robot. The specimen comes out, but you don't get the report of the histopathology immediately. So the specimen goes to laboratories, and specialized doctors called pathologists look at Kaveri's sample under microscope to see how and what is the pattern of the cells in that organ which has been removed, to see if her cancer is back or not, or if it has spread or not. Now there is always man and machine competing for time, and all of these remain unseen and unheard behind the opaque walls of results not yet ready. Now, this is our hospital sterilization department. We all know about COVID now, and the importance of gowns, and how all the things, everything needs to be sterilized in a different way. And these trays, which look like dinner trays, but actually they have surgical kits for each of them. So somebody who needs a minor suture, usually doctors take out one tray, and all of that has the bare minimum necessary equipment so that it's sterilized one at a go. And that night came, Kaveri was in the hospital, lots of patients, and everybody has their own diets which are medically determined. The kitchen works 24/7, and the food might not be tasty, particularly if you have cancer. Nothing is tasty. Life is not tastes sour then, but you do need nutrition, because you have less side effects. You have to live. You can't be given nutrition intravenously only. So the kitchen staff work, and we don't see them. And slowly after the night, the dawn becomes, the sun rises, but the hospital keeps working. So the nurses tries to get ready. There are fewer number of staff in the night, and Kaveri needs chemotherapy. Now chemotherapy, we don't know all that, these are the three nurses who are preparing chemotherapy, because they're quite toxic. And so there are specialized cabinets within which they are prepared, in the sense that you take it out from the vial and load it into the syringe. And this is in our daycare, and the person is in the bed. The elixir of cancer treatment, chemotherapy, it's very clear. And I think sometimes we do fall short, because we become quite blurred about the people behind it, including the patient. And Kaveri gets better. Lots of questions to nurses who may not have all the answers. They're perplexed. Day goes on. Some people may not be as lucky. So this is our palliative care ward with a nun sister who is also a nurse and a nun sister, so that the unit works harmoniously. In the department, I represent palliative care and psycho-oncology. And many patients get admitted, not necessarily for hospice care, but for symptom management, and then they go home. Some patients get better, like Kiba. She was from Sikkim, and she was fine and was leaving. This was the day she was leaving. And Shubir, at the end of the day, again the next day, goes back home with one more day, trying to get ready for the next day. Thank you.
I think as you realized, so I think Soumitra's aim was to, and this is part of a much more bigger exhibition which has been displayed in many other places, and the exhibition also, personally I remember it was, I think, involved about 6 or 7 halls and rooms, and when you go through from one room to another, personally again it was a very strange experience for me, because I feel that cancer has so many threads, and it's a very rich tapestry of emotions, and with also surprising resilience. It's not just stories of despair, but also stories of determination, great points where you feel extremely low, and then points you feel again quite energized. And so fortunately, I do know a lot of people who work behind the scenes, and it has always been a mystery of how they feel, how they feel and whether they do realize the pain. Because I think increasingly, as all of you would realize, that medicine is becoming very dehumanizing. I think that is one of the commonest complaints. And there are many, many reasons, and I personally feel that being a doctor is one of the most scariest profession in West Bengal. But I think there are many reasons why, from both perspectives. So I think we'll open it up for questions, but I would also like to, ask that what kind of feedback have you got, from people and from where you have spoken about it, and then, we'll open it up for questions, comments, thoughts.
Yeah, thank you. I had very surprising feedback. So most people were very moved, particularly staff, because actually even within the hospital, a lot of staff don't know the intricacies of working of a different department. When I was doing this initially, people didn't have much idea what it's going to be, but because I have been there for long enough, people had that faith that he'll probably do not something bad for us. So we even recorded sounds for each areas, which, so for OT has a different sound, OPD has a different sound. And I think there was a bonding for the staff team, those who were photographed at that time, and patients who had come to visit, and members of general public who had come to visit. I think they also appreciated the effort, because it was demystifying for them that how it works. And there were, we didn't do small pictures, so the very big pictures on glass we had put up when the phase 2 had started. So yes.
Yeah, because they were also very, very, very large pictures. The photographs were quite large, so it was I think more than life size.
Yes.
Sizes. Yeah,
so it was almost as if, from what you're describing, it was almost as if you'd walked into a space.
Correct.
Yeah. Right?
That was the idea.
And I think for me, immediately, what struck me about the frames that you showed was the fact that it was in a way a tribute or a homage to the people who were in attendance, who were the caregivers. So definitely you've also established some sort of a relationship, and in that it is not really a desensitizing or a dehumanistic experience.
Yeah.
So I'll just pass the mic around. Would you like to start the... Okay.
Hello, doctors. Thank you for that very wonderful talk. And I speak from personal experience. I've been there many, many, many times, because both me and my husband have had it. And I think there could be no better place than the Tata Medical for this kind of treatment. And yes, let me take it from the beginning. You said about scary. I think maybe this is what, maybe one of the only hospitals which is not scary, which is actually not scary. And he spoke about opacity. No opacity at all. It is all very clear. They don't beat around the bush. They tell you how it is. And I mean, you're not in any way under any illusion about what you have to undergo, what you have, what your, say expenses will be, everything. And I don't know if you give your staff special training, but as far as we have been concerned, each and every person, staff of the hospital that we have come in contact with, has been so good, so kind, so polite. We are absolutely floored. I mean, you can go and ask that receptionist 10 times, Didi, amar kobe, when will my turn come? And she'll say, wait. She'll not scream at you, I've told you 10 times, wait. No, she'll smile and she'll tell you. I don't know if it's your training, I don't know if it's the Tata aura or whatever that does it to your staff, but it's like that. Yes? But what I want to say, my question is, what he was saying was that once you've had this, it's always at the back of your mind. And I know it's at the back of mine. And every time you have something which is a little more than just a cough or a cold, you feel, oh my God, I mean, it's like that. So how does one know how to differentiate when it is and when it's not, and when one should go in for another checkup? Or that's what I want to know.
Yeah, I guess, so there are two parts to this question. One is that as psychiatrists we would address is, which is the fear of recurrence, that will I get a recurrence? And that happens quite often in the first few years of cancer survivorship. So I had a very interesting lady whom me and Rosina used to treat. So she came to me and said that, Angelina Jolie did not have cancer and she had double mastectomy. Exactly. I have a stage 3A cancer or 3B, I've forgotten, and I had breast conservation surgery. What chance do I have? So the idea there is to communicate and explain that, she had a familial cancer, so chances of that being expressed is 80%. So that's why she had what she had. Your having mastectomy wouldn't have reduced the chances of recurrence, so breast conservation surgery is fine, and you just follow the doctor's advice. Now, this particular patient, she would come on Saturday, on a Thursday, and get that scan done, mammogram, or sometimes would come to the hospital and not even get that scan done, would get scared, go back home, what if I have a recurrence, and come back again roam around and go back. And so what we did, me and Dr. Ahmed, so we realized that, she is fearful of, having a recurrence, so we will do the scan always on a Monday. And we will talk to the radiologist so that she doesn't have to wait for a long time when she gets the news that the scan is fine. And after 3 years of normal scans, she was not scared anymore. So that's one way of dealing with it. For the other question, the physical part of it, that when do you want to go back to a hospital? Now, I think if there is anything out of the ordinary which you are thinking, because there are certain cancers where you can do some tests. For blood cancers, you won't do a bone marrow every few years to screen if you have the cancer back. But if there is anything out of the ordinary, I would be, we are both humble psychiatrists, so I would leave that discussion between you and your oncologist to have that. But if this, in spite of the reassurance, this thought is keeping you awake, that's when we get into the picture.
No, not exactly keeping me awake at all. I mean, I sleep very well, thank God. But yes, it does occur in my mind. Like, I've had some gastro issues for about a year. And I'm sure they're just gastro issues.
Yes.
But, it does occur to me now and then. I mean, is it something else? So
I think the fear is always there, isn't it? I think the way I look at it is, the longer you are free of cancer, the chances of it coming back is increasingly less. So I think 4 or 5 years is one of the ballpark figures which people say. rarities do happen, but I think the longer you are free of cancer, you are, yeah, I think that is one. Can I just tell you about communication skills in cancer in Tata? Actually, Soumitra takes communication skills training for them. So a very close friend of mine was getting operated for breast cancer about 6 or 7 months ago in Tata. And so I had gone there to meet her. And now I have a fairly supersized ego. And so I went there and I wanted to go. And I knew that they were in the OT room. So, you know, I'm a doctor. So I thought that I will just go into, I will introduce myself and people will let me in. So when I go and there is this security staff and I introduce myself, I said my friend is getting operated. So he says in Bangla, sir, already এমনিতে তো ওটিতে দুজন অ্যালাউড ওটি লাউঞ্জে অলরেডি ওনার হাজব্যান্ড আরও দুজন আছেন সো আই নিউ দ্যাট মাই ফ্রেন্ড অ্যান্ড দেয়ার টু ডটার্স ওয়ের দেয়ার বললো অলরেডি তিনজন আমরা দুজন অ্যালাউ করি আপনাকে তো স্যার যেতে দেবো না মানে আই ওয়াজ কাইন্ড অফ আল্লাম ওরা তো বাড়ির লোক এরকম আল্লাম যে না স্যার এরকম আমার খুব মুশকিল হবে আল্লাম আমি ডক্টর রাম আমি এই সো হি ইউ নো হোয়াট হি ডিড হি সেড কাইন্ড অফ হেল্ড হিজ ইয়ার্স সেড স্যার আপনি আমার দুগালে চড় মারুন স্যার কিন্তু আমি যেতে দেবো না And I thought, what can I do after this? I said, you know, I have seen many people.
So obviously you're doing something very right.
So then
to train
I
the
called
guys.
up, so then I called up Soumitra and I went through the back door surreptitiously avoiding that security guard and then he later told me then my training is working. But I was really impressed, you know, because in other hospitals they would be rude. This guy just kind of held his ears and said, sir, apni amaye dugale chor marun sir, kintu ami apnake jete debo na. I said, you know.
Brilliant.
Reena.
Please, would one of you like to?
Yeah. The photographs were brilliant. I have, first-hand experience of Tata Memorial because my husband till he died on the stretcher in Tata Memorial Hospital. So for a month and a half, it was like every single day. So, you know, it was. So I'm not going on this emotional kind of journey backwards. But what I will say is that, Doctor, I think it's very efficient. People are very matter of fact. But I do believe that because of the huge waiting times, I think a certain degree of communication skills, better communication skills, would actually be very helpful. Because, you know, patients differ from their ability to take that kind of rigorous waiting. And there were times when we waited for 10 hours. You know, we've gone in the morning and, you know, we've waited there till the evening. And my husband would get and I teach psychology too. And I work with communication too because I work with people with disabilities. That's my work. And I work with people who have no speech. So I actually work with people who use augmented communication. So I look at people's communication skills. I do believe there is much more work required for better communication. They're very efficient. I'm not talking about efficiency. I'm not talking about matter-of-factness. It was fabulous. I would say, given the kind of demand on the services that there is, and given the fact that they don't make a difference as to who you are and which socio-economic group you come from, you're given this, you know, one wonderful level of service. I'm a great admirer, but I do believe that regular courses, training courses, in just communication and just that slight bit of empathy and a slight amount of, you know, when Ashish died on that stretcher and it was in the middle of the night at 2 o'clock or something, And we were absolutely on our own, my daughter and I, because we didn't know he was going to die. Nobody knows, but he wasn't even that, we didn't think he was going to die. And there was just nobody around us. And we had to just figure it out. Now in a cancer hospital, it can happen, right? That people do die at odd hours. It can happen everywhere. But I did feel that gap. And I wonder, this is not sort of some kind of, a kind of going back in history, but I just want your views on this. Is there scope to actually build up better supportive communication skills, particularly for bereavement and loss, or when people get really, really ill and when the cancer is raging and there's not much hope?
You must have had a horrific experience of I'm so sorry for that. And I appreciate that the question is not about that or a critique of that experience. Yes, I understand that. I completely agree. If you see the last 100 years of medicine, so we are focused on cure and getting rid of diseases. Now, if you look at it statistically, even for the high-income countries, so India has done something really well. So we were having a survivor, average time of 33 years when we got independence, 1947. So now it is almost 70. Now I believe that with better technology, better medicine, this won't become from 70 to 140. So this, in UK and other Japan, it's more, yes, 80, 85, but there would be a ceiling. And now is the time where you need focus on how to accept and embrace end of life in a dignified way. And the medical establishment also needs to be rising to that, otherwise there is a heartbreak on both sides. And I completely take your point.
And the fact that more people have not come is because the word cancer, anything to do with cancer, it needs to be demystified. And people need to be more accepting about conversations about end of life. When I said I was coming today, at least 4 friends said, "But why? Why would you want to?" I said, "Because I would like to know. Because I feel these issues need to be discussed, because it is truth." Yes. But we need as a community to kind of talk about these issues and, sort of be more open to discussions about grief and loss and bereavement and end of life and all of this. But also hospitals too.
True.
There has to be a system.
Yes.
No, I think you're absolutely right in the sense that as physicians, we are, we don't talk about death and the fact that what are you going to do? Often, I work in a general hospital where to break very, very bad news, now it has got better. So you have someone with ovarian cancer, you have a young child with, say, a bone tumor, which is not going to people know that this person is going to die. Now, how do you have that conversation with the young person, with the parents, and because they are already, they know the whole thing, but they don't know that this is not going to, we are not going to live. So maybe in the next puja, I'm not going to see. The next, and there is a huge amount of denial in the sense that I am going to die. And I have seen it from very, very personal experience that very high intellect people, they know that they have cancer and they are having conversations about buying a new car. When I personally know that they are not going to live for another 2 or 3 months. So, and it is very strange how so actually my question is also, how far do you push as physicians, doctors and nurses to bring out the truth? You are also here because you are also a cancer, surgeon. So therefore, how much do you tell people? I remember when my aunt was dying of cancer, gallbladder cancer, about 30 years ago. As a family, we decided we are not going to let her know that she has cancer. And there was this whole charade of thing. Now, and a lot of people, we felt that what is the point? Now, this is a very, very difficult choice, that how do you, one, I think Rinadi's point is at that sheer moment of panic and, the world sinking really. I have this, his heart sinks really, that what do you do, how do you support people, and also how much do you tell people that, see, this is going to be it really.
Yes.
So would someone else like to ask a question?
Sir, my name is Dr. Saurabh Bhattacharya. So I work as a professor in a dental college in government sector. Yeah. I work as a professor in a government dental college. And we see a lot of oral cancer patients each day. So my first question would be a bit awkward for you, and I will seek your apology beforehand. Why have you chosen black and white photographs for this? Wonderful photographs, of course, but why is the medium black and white? I'm just curious.
This is, I'll be honest. One is that because I wanted this project so it was not only me, so it was a group thing. And it was an artistic project. We wanted to explore the emotions. And the project was called The Only Journey is One Within. And we felt sometimes colors may mask the emotions. That's why we had taken. The photographs are color, but the book is a black and white book. There was a very, very practical reason for it also. Printing good quality colored pictures may be actually much more complicated than designing it. And I had no clues. Thanks to Dr. Ram, he introduced me to some of the people who gave good inputs into design and some friends. And we actually designed it in the department, so through softwares. So, and some artist friends who helped in designing it and printing. So we didn't have a sort of budget for getting a proper publisher, because I was naive when I first negotiated with King's, and not that they had refused, but the MOU had already been signed. I think there are views on both sides. You can put some color pictures, has a different meaning, and probably gives more hope. I wanted to reach into the deep emotions, and hence I stuck to black and white. But neither is wrong.
Thank you, sir. Sir, how do we break the news to the patients at the first hand, when the patient's first time he's going to get the report, which we do all the time, as sir was saying. And these are generally the masses. I should say the underprivileged part is more. So how do you break the news, sir?
I will also tell you, just to add to your point, is that often I'm called to see a terminally ill cancer patient in the ward, in the oncology building. And and whenever I leave, I will say, I remember yesterday I will shop thik hoye jabe mashima. I know I am lying. So she's not going to get better, So there is this whole kind of, so do I tell her that it is, she would ask me, je kobe badi jabo, ki hoyeche, because often I am a new person, I am not part of the team, and she might have asked the same question to a lot of other people who must have given a answer which is not to her satisfaction. So, as you said, je ami ki bolbo tale, ami ki bolbo je na apni, you are not going to go home. So it's also personally for us, it is kind of very difficult. Yeah, but
yeah, meaning I think no amount of skills can make a bad news good news. So bad news will remain bad, but I think if you are humane and you understand why. So I often ask people, what do you want to know? And if they have a specific thing which they want to know, a lot of people ask me, how long am I going to live? And I'll tell you the scientific aspect and the psychological aspect to it. So unless somebody is dying in the next 24 to 48 hours, actually you won't be precise about it. Now, median survival with which oncologists talk about it, so it's like 100 patients with that cancer, if they're arranged in orders of small to big, what is the duration of length? The 50th person has remain alive. Nobody has ever asked me that question. If there are 100 people like me, they are wanting to know how long will my father live. And my answer to that is I don't know. I think in English, this weeks to months, which is, I think it's a very euphemistic way of saying I don't know. So the more important question as a psychiatrist for me is to understand why is he wanting to know how long have I got to live. So go into that narrative about, does he think that he has a son whom he wants to get him married, which is impractical, he's in third year and, you don't want to wreck a young man's life by just getting somebody married because father is not well. On the other hand, if there are practical things which can be done. Now, of course, you won't go and ask somebody, tell me about your final wish, but we could always ask it in a much more gentle way. Could we do anything else now that we are having this conversation? And I think if you start discussing about it, there is always things which you could do something about, even in a terminal situation. I think patients have a right to know, and if I don't know, breaking bad news is usually done by oncologists. We often sit with them if there is a person who would want help from us, and we would do it together. If they ask us figures, what are the chances of recurrence with this treatment, the oncologist tells that. But I seldom people are actually behind numbers. They're actually wanting to know how life would be after this. They're not interested. It's very difficult to personalize 16% to your life or 76% to your life. So I'm always for the story.
Hi. So we've heard a little bit about the perspective of the patients basically who go through that. But from the perspective of us, the caregivers, sometimes, let me put a situation where suppose we see a lot of tobacco users, and in every of our aspects we try to give them counseling about, not being a psychologist also, about cessation of tobaccos. And I have seen patients, suppose, for 40 years they have taken tobacco. And every time the patient has come, I have asked him to stop tobacco. He said, okay, chal raha hai, all these things. Now suddenly it happened that after a year, the patient came after stopping tobacco. Now the genetic parts and all those about cancerogenesis, I don't know to. The patient came with a very small lesion. Now what happens, we deal with these lesions every day. That's why a patient having a very big cancer, that anyone, even my staff and all can say, okay, this person is having a cancer, something like that. But a very small lesion in the very initial stages, we can make it out, okay, this is not. So as usual, I did a biopsy, it came out to be malignancy, squamous cell carcinoma. Now that person standing in front of me, Dr. Sir, for last 40 years, I had been having tobacco. I have been meeting you for last 10 years. You have been asking me to stop the tobacco. For the last 1 year, I have stopped the tobacco. And today you are saying that I am having cancer. Now how do I deal with the situation? What would have been I dealt it with the way I could have. But I thought that I wasn't good at it. And I didn't have proper answer to that. I couldn't. So
yeah, I'll give you the scientific answer to it, that the cumulative risk of tobacco causing cancers, so if you have stopped using it for some time, around 40 or 50 years of age, after 15 years your risk goes back to the population level if you had not been smoking. But it's very difficult, and this is something which we face all the time with, as psychiatrists at adolescents. People have high risk behavior, not everybody has the bad outcome. So I think at that point I would the question behind this is actually the guilt. The question is that, have I done something wrong? I don't think the question is, should I have continued and then I wouldn't have cancer? I don't think people are, he has come to you 10 years. So this is somebody who is aware about his health needs. And I would, at that point, once they have developed the cancer, I would focus on that they don't go back onto tobacco because of desperation and thinking, who cares? And they don't feel overtly guilty about their 40 years of habits. And I would focus that, our eyes in the front, let's do what can be done. Your lesion is very small. I think, follow the head neck cancer surgeon and whatever has to be done. And don't feel, what you hadn't done. Those are regrets we all have. So there are small regrets which people have. So I think you focus on the future would be my focus.
I think also one of the very common question is, why did I have it?
Yes.
Keno amar holo?
This was a person who was having tobacco. We see a lot of patients who don't have tobacco also, and they have young aged female patient presenting with an ulcer, and we find it out to be cancer.
Yeah.
We have no answer to that. Why you are having it, and making her understand that,
a 48-year-old, I remember about 4 or 5 years ago, a 48-year-old woman, absolutely kind of life going smoothly, had ovarian cancer, and she also, and then she asked me, she was, that why did I have it? So what do you say?
They just give you a leaflet, which some people read and some people are too scared to read. But if I may suggest, there should be some conversation about the after effects of chemo and radiation, because they're quite extreme.
Yes.
And I think if the patient and the primary caregiver, they are not prepared, it can be very frightening. Because you don't actually realize how bad it can be. You've read about it that it's bad, but it's still in print. But I do believe that the oncologist, the consultant, or somebody in the chemotherapy department or in the radiation department, wherever, they need to have some conversations about this. Is this feasible?
I think, I entirely agree with you, and I think there is a conspiracy theory. Because they never tell you about the side effects. They
because
never
it
tell you
was
about
just
the
the
side effects.
most frightening thing.
I have arrived at a logical conclusion, or kind of illogical conclusion, that if they tell you, because I have seen people receive chemotherapy and they will run, but they never have, and they minimize it. Ektu hobe, hat pa jhin korbe, kind of cytotoxic drugs which are peripheral neuropathy, they are. So, my aunt is not able to wear her slippers, and she, ektu hat pa jhin korbe mashima. But I think they deliberately.
But Dr. Datta, really, this is I think, a genuine request.
Yes.
That there has to be better psychological preparation for acceptance of cancer treatment and the after effects of cancer treatment. Because it's really scary.
Yes.
I don't know.
And I think, I also take the point that leaflets are bibliotherapy, isn't it? People may not actually read leaflets. So we have been trying to do with an organization called JASCAP. We did that for leukemia, lymphoma, and oral cancer. Having some information on small videos, so 3 minutes, 4 minutes, for chemotherapy, for radiotherapy, for bone marrow transplant, leukemia. Now, of course, certain cancers would have it more than others. Like breast is a superficial organ, so the impact of the treatment is less. And I completely agree that there is that always this doubt that if I am scaring the person more so that they turn out, or I am being transparent. It's a struggle which. Please do.
Yeah, what I have to say is that a lot of people can't really take the truth, as it is in its absolute raw form. So, in my view, it is a doctor's duty to be a little more circumspect, to be more diplomatic, and to get around the point, tell him you're sick or tell her you're sick, but also not scare her that she will maybe die sooner than she would have otherwise. So I think it's all right to say, Mashima, you'll be all right. I mean, in my mind, I think that's okay. I mean, having been through this, I know what it's like. My chemotherapies were awful. My husband will bear witness to that. They were absolutely awful. But at the end of the day, from the morning to the evening, I've been there taking that intravenous. But when I went home, all those nurses were smiling. They were, seeing me off so nicely. They were saying, you'll be okay tomorrow. You'll be much better. You feel like, and I know that it's not going to be like that. But to hear them say it makes you feel better. So that's what I feel.
I think hope is a very important part,
Exactly.
isn't it? And I think I don't think it would be right to take away the hope.
Yeah. And I also have a question that if a person is absolutely normal, I mean, supposedly, how and when does one know that one actually might have that malignancy inside?
No, I would say, you should, if you're absolutely normal, just live normally is the best way forward.
See,
By the time it comes to know something, it's already spread.
Not always. Yes, but if you are, yes, it is a life-changing time when you go through that. But there are standardized ways of, so somebody who has breast cancer, people have seen how often if you have a mammogram is good enough. So why can't you have it every 3 months instead of a year? So there is a science behind it. Now, if I can take that particular example of breast cancer, say in Switzerland, so there is a general population screening for everybody free of cost after 40. Now, they realize that cancer is being diagnosed so often, say somebody in 85 and you develop a T1N0 cancer, that lady may have had a natural death. And that's true for prostate cancer as well. So, being Switzerland, they had actually voted. Some of the districts said we won't have further screening. Some of the districts said we would continue to have the screening. And in that setup, people showed that the issue is by having those tests and treatment, are we saving lives? So that's called numbers needed to treat, to save lives. And they showed that in Switzerland it wasn't. But in a country like us, I think screening probably would help. But again, that's not my area. But I think, ideal health without any disease is almost utopia. So if you're doing well and your doctor said that you come back after some time.
I am one of 4 siblings, the
Okay.
oldest. 3 of us have had cancer. One has
Okay.
actually passed away from cancer.
Yes.
And we are the other 2 who are now still living, the ones who have had cancer. One is even now going through it. We are so scared for our youngest brother because, I am so open with my brother, but this is the one thing I don't discuss with him because I'm so scared,
True.
And I don't know,
I think there are certain cancers you can screen and prevent and catch it early. I think colon cancer is one of them.
Yes, hereditary
Then-
breast and ovarian
yeah.
cancer. Brother won't get breast or ovarian cancer. That's one good thing.
But the other brother one brother had a liver cancer, and the brother who's still alive has a lung cancer. And
Yes.
he's in London, so he's being taken very good care of. He's just had a second a lung operation of the left lung, and I believe he's doing very well.
Okay.
And
That's good. To know.
yeah, but whatever. It's so scary. I don't discuss this with my youngest brother because
I think one of my cancer surgeon friends told me that I asked him that what do I, because I also have a very strong family history of cancer. Said that if you live long enough, either you will die of cancer or of dementia. Now you need to choose which one you want to die of.
And my father had dementia. And my father had dementia.
So I think there's an amount of kind of, so I think if we live long enough, now that if you have survived, I think your 40s and 50s, most likely you are not going to die of acute myocardial infarction. And if you don't have diabetes, then possibly kidney failure and all those things won't happen. So you are most likely to die of cancer. I think that is the reality.
Very encouraging.
Thank you. Thank you for that wake-up bite. I have a question, actually a comment, and would love to hear your views. We've all talked about a certain age where we face these issues. What about children? I remember one of the things that will always remain in my mind is visiting the sick children's hospital in Toronto. And it is remarkable how children after the age of 10, between 10 and 15, are given the kind of counseling with the truth pill. Nothing is hidden, but it's, parents, visitors, those who are volunteers, we go in and they've accepted it. Yeah. That they hope it won't end in mortality. Everybody wants to be immortal. Kids are no less. But on Sundays, even if they've gone through chemo, they are taken out by the father to play, either to play a hand baseball or whatever, to make it as normal. There's no howling, ki holo re, amar cheletar ki holo re. None of that. Yes. So as a psychologist, psycho-oncology as you call it, how do you think we are faring with counseling children?
See, I think this is a very question close to both of our hearts, because both of us are child psychiatrists. So I think good news with children is that children's cancers are actually very, very curable. So lymphomas, leukemias, a small proportion of brain tumors, that doesn't have. So we are talking about 80% cure rate. Sarcomas are not. So bone tumors are not, but the leukemias, lymphomas, which are the commonest cancers. And we did somebody did PhD from IIT under me on this information needs of children and adolescents with cancer. So what we felt, that very young children, their need was, like they wanted to know, will the bone marrow test be painful? How many times will the nurse take blood? Whereas adolescents, the information was that, adolescents don't think in very long terms, will I live till 40? But they ask, their information need is like, will I be able to go back to school in 2 months' time? Sometimes some of the adolescents which are slightly older did ask the nurses that, will I be able to have a child and things like that. So those, because of the hormones and puberty, I think those thoughts are coming. And we try to, address the information needs in a child-friendly way. May not be as good as Sick Kids Toronto, because that's the world-famous center. But I think our children's ward, you're welcome to come and visit this thing. So we have a playroom. We have, therapists coming for play therapy, and teachers coming for a little bit of teaching. Many of the children's cancers, actually, you need admissions for prolonged times, which is not true for solid tumors often. But, of course, we often find children's parents, in our country, they would say, oh, you have got better with cancer, you don't need to go back to school. So that's actually, counterproductive. And often our job is to empower them to say that you have to treat, this child is treating the family, the entire family is running around the child because he or she is a cancer survivor. And we have to just tell that you need to be a mother there and put boundaries. Now the child doesn't have cancer, and let him have a life, but at the same time you need to do what you would have done and anything. So children's cancer overall outcome is better. You want to say anything?
Yeah, I think your children ward is, I think, I have seen pictures and I have been there once. I think it's a very cheery place. So it's a very unlike, and they have excellent therapy services. So, and his area of specialization is actually in working with, so I think that's very.
I'm slightly digressing from what was being discussed. I recently saw a film on how rivers in Punjab are getting polluted because of a very interesting fact. Punjab is one state in India where, even small towns are completely industrialized. And a lot of pollution is being just thrown into the rivers because the state government is not able to control that. They don't have the machinery. And Punjab is gradually becoming the cancer capital of India. Is there any truth in that?
See, this is a difficult. First of all, I don't know specifically about Punjab and the statistics. It's a very specific question, so I won't, comment. But in general, because we are living longer, the chances of us actually. So this could be a secular trend. See, Punjab is a wealthy state otherwise, so they have all the reasons why your life expectancy will be longer. So internationally, we don't know the actual number of cancer is increasing, or is it a secular trend in epidemiology. Also, there are more facilities now. So 30 years ago, a child may have had fever and die after 3 months. Nobody would have thought of leukemia. But now, even villages would have a center which would do a total count and would see a blast and make a diagnosis that this child may be having leukemia, and you access help. So scientifically answering your questions, what I've heard from talks from my oncologist friends, is difficult to say, is this a secular trend or we are picking up the cancer more? But of course, there is no doubt that, like tobacco smoking and, other environmental factors, they contribute to carcinogenesis. And is that true in particular for Punjab? I don't know, but obviously that would play a role in changing the DNA of a person.
Sir, we frequently encounter a lot of stress or anxiety-induced immunological lesions. Sir, is there I don't know, sir, I'm just looking for opinion. Is there a stress, anxiety, personality trait which may be more prone to carcinoma?
Yeah, in general, as I was telling in the beginning about this psycho-oncology joke, if you have a personality which makes you prone to take more risks, be it tobacco, alcohol, those may trigger the cancer, but in itself personality or a psychiatric diagnosis leading to, because of the diagnosis. So, I'll give you an example, say schizophrenia. So schizophrenia patients often feel drowsy because of the medicines we give, and internationally data supports that there is more tobacco use in schizophrenia than the general population. So obviously they would have more lung conditions, but that is the moderating effect or the mediating effect is the tobacco use, which is triggering the medical illness, not specifically or maybe the medicines we are using and things like that, but not in itself the diagnosis. So I think there is, to date, most of the research which has happened, there isn't anything which has been identified that this is a predisposition, strong risk factor for cancer. However much people might think, I won't want to take that kind of credit. We deal with reactions and certain behaviors which may lead to cancer.
I have a grandson who has vitiligo.
Yeah.
And he's a grown-up man now. His little grandson is now 25. And he's a very stable-headed, grounded kind of a fellow. But this last time that he was here in Calcutta to visit us, one of the things that he asked, I was so taken aback. He said, Dida, do you think I can get cancer because of this? I said, don't be stupid. I didn't even want him to think about it, to dwell on it. But children think about it, or young people think about it. So how do you deal with this?
I think, he has skin cancers are common in the West, and if you have less melanin pigment in your skin, you become more prone to certain radiations, and also there is something to do with the atmospheric pressure and all that. So I think skin conditions. He may have had friends who have had parents dying or diagnosed with melanoma and things like that. I am unaware if vitiligo directly is associated with cancer.
In many such situations, what I do is I say, let's do a search together. And let's do a Google search together.
That's a good strategy.
With the patient. You tell the
With the
patient.
person. So I will tell
Okay.
your grandson that I don't know. I don't have the answer.
Yes.
I think what often many of the young people we see, they say that we don't like not being taken seriously, because see, it's such an emotive issue. How you can, as your grandmother, even contemplate the thought that your grandson might have a greater chance of having cancer? But I think if we steel ourselves and kind of say, let's do a proper search and see what we get, I think that at least reassures that if I have a worry, I can come back to Nani and ask further questions. So I think that is one of the very common concerns expressed by a lot of young people when they ask about something provisionally bad, or something which is life threatening or something of a scare. Then many of us adults recoil from that idea, and then they never get a chance to address it. So I often do this because people ask weird questions. These adolescents, they have certain, and you really don't know. So we do a Google search and say that let's know, because I don't know.
Yeah.
Thank you.
I think if there are no more questions, then we'll end this session. I expected a lot more people, but maybe because of the subject and because of other parallel programs happening, we did not have a expected number of. The rains are also there, yes. But I must thank Dr. Soumitra Datta. I've seen your book. We have talked over the phone but never met really, and also thanks to Jaja. In fact, I came to know about you thanks to Jaja. And I personally feel we had a wonderful session, and I hope that we will find other opportunities to do a similar kind of program later on. And just as a token of appreciation, we have something from the club.
I will leave these two books for the